In this short overview, I will discuss current and emerging concepts for PFO closure with a minimal footprint, why safety matters most in a prophylactic procedure, and where suture-based and bioresorbable approaches may fit in the future. These are my disclosures. So why to reduce our footprint? We are interventional cardiologists. We really like to leave a big footprint. Well, why do we want to have suture-based and bioresorbable devices? Because patients do not like piercing, even if it is only internal piercing. Because metal framework may cause erosion, arrhythmia, thrombus formation. Aortic valve leaflet distortion has been described. Also, we want to have resorbable devices or suture-based devices to make future transseptal access possible for EP procedures, for mitral valve interventions, or for LAA closure. And then the anatomy of the interatrial septum can change in the elderly, and there may be a risk of erosion decades after device implantation. And we just recently had a perforation 14 years after ASD closure. And also there are concerns about nickel allergy. My sister has a PFO and had a stroke. I have a PFO too. Why should I wait for my stroke? That is something we hear more and more often from patients coming to us. I'm sure the next big step in PFO closure will be primary prevention. We will treat not patients but healthy individuals. Safety will become even more important than today. What is the ideal PFO device? It has to be safe, close to zero risk, not only acutely but also for 80 years after implantation. Why? Because that is the life expectancy of some of these patients. And that means we are talking about the year 2106. Nickel-free, because many patients have concerns, even if not justified. And many of them are left untreated. That's actually a frequent reason why patients come to us for PFO closure decades after the event. And the ideal PFO device does not limit access to the left atrium in the future for other interventions. Nickel allergy is one of the most common reasons why patients ask for a smaller footprint. 8 to 10% of women and 1 to 2% of men are sensitive against nickel. Complications in patients with nickel allergy are well known and described in the literature. Stents, pacemakers, orthopedic implants, dental and orthodontic materials, nitinol coils, ASD, PFO devices, all this is documented in the literature. These complications are widely underreported. Why? Because the relationship between nickel and the adverse event is not always obvious. Very often adverse events also can occur without nickel allergy, just more frequent in those patients who have nickel allergy. In general, we tend to ignore problems as long as we do not have a solution for it. This is one of the early reports. Patients with nickel allergy had more migraine and chest discomfort after ASD closure, as you can see here from this publication back in 2006. This is a recent publication about nickel allergy in a patient with a Gore device, and this is really well documented. I cannot go through details here, but at the end the device was removed and all the symptoms disappeared in these patients. All current available occluders contain nickel. According to the IFU and FDA, they are contraindicated in patients with nickel allergy. What could be the game changers in PFO closure? Well, suture-based closure devices, bioresorbable devices, and closure techniques leaving nothing behind. This is how the suture technique works. You apply one suture to the septum secundum, another suture to the septum secundum, a primum, and then both sutures are brought together and fixed together with the so-called quick knot. This shows you an example. You see the device for the septum primum. Then the needle is fired, which applies the suture through the septum secundum. And then the next step, the device for the septum primum is introduced. Also a needle is fired, applying this suture for the septum primum, and then both sutures are brought together. Does this technique work? Yes, it does, and I could show you many examples. We have done hundreds of cases now. You can see a follow-up in a patient who underwent PFO closure with a suture. And here you see the sequence. This is before PFO closure. Then you see the noble stitch. The little quick knot can be seen on echo. And on the right side, you see the follow-up TE with sufficient amount of contrast and good Valsalva, and you can see there is no residual shunt. There are other emerging suture techniques. It's still too early to emerge them here in this lecture because it's still confidential. So in summary, suture-based closure of PFOs, the advantages are some problems simply cannot occur, like device embolization, erosion, problems in case of nickel allergy. Some problems are very unlikely to occur. For example, thrombus formation is extremely rare. Atrial fibrillation is very rare. Only a suture is left behind, which is a psychological advantage by itself. There are also limitations, of course, and these include it requires a PFO tunnel of at least 4 millimeters length, and the success rate is lower than with devices, 80% versus 95%. And there is a learning curve. It's certainly more difficult than to close the PFO with a regular umbrella. Now let's move on to bioresorbable devices. And over the last decades, a couple of different devices have been invented and evaluated. Some of them are not existing anymore. Those who are left on these slides, they are still either in clinical trials or approved in some areas of the world. This is the Karak bioresorbable septal occluder. We did first in men more than 10 years ago. It's made of a PLGA framework. In this device, the patches are not resorbable. They are made of polyester, so they will stay. It has some markers just for visibility. It's suitable for ASDs or PFOs with short tunnel. And currently there's a study ongoing in the US focusing on ASD closure. This is the other way around. In this device, the DeNova PFO occluder system, the framework remains, that is made of nitinol, and the membrane is resorbable. So this is a good device when you are concerned only about access to the left atrium for later needed procedures. This is the AppSnow occluder developed by the LifeTech company. In this case, everything is made of resorbable material. They have ongoing clinical trials for ASDs as well as for PFOs. This is Mellow Medical. In this case, again, the membrane is made of polyester fabric, so that will stay. Only the framework will disappear over a time of 1 year. And then we have the Lepus Memosorb ASD and PFO occluder. They are also working on VSD occluders and other occluders. These are made of PDO and PLA. Both eventually will become carbon dioxide and water, so they are resolved completely. This device is approved in China, and more than 3,000 cases have been treated so far. This is our first case, and back in 2023 we can use this device in compassionate use. You can see the images before and after. The patient was just here for follow-up, and there was no residual shunt, and the device is not visible anymore on TEE. These are the trial. They recently published a randomized trial in ASD patients, bioresorbable occluder Memosorb against metallic occluder. At 6 months, the success rate of ASD closure was 96% for the bioresorbable occluder versus 97% for the metallic occluder. So there was no difference, no significant for non-inferiority. At 2 years, there were no significant differences regarding effectiveness and safety of this device compared to metallic occluders, with the exception that it resolves over time, of course. And now let's move on to the latest technology. This is a technique designed to close the PFOs without leaving anything behind, so no occluder, no resorbable occluder, and also no suture. And with this device, we clamp the tissue in place, so the septum secundum and primum are clamped together, and then radiofrequency is delivered, which results in closure of the PFO. We did some animal tests a long time ago, then the project was stopped for various reasons. On the right side, you can see the fused septum primum and septum secundum in this animal, and on the right side, an image from the control group. So in summary, PFO closure was invented more than 3 decades ago. Current devices are safe and effective. Future devices have to be even more safe because the next big step in PFO will of course be primary prevention. For many reasons, a closure technique leaving nothing behind will be preferable. Suture is one future, another future will be resorbable, and another one will leave nothing behind. In my opinion, minimal footprint strategies may become increasingly relevant as we move towards prevention-focused PFO closure. Thank you very much for your attention.